Hi, everyone. Thank you for coming to our virtual poster presentation. My name is Tim Miett. Acute promyelocytic leukemia, abbreviated APL, is a rare subset of AML characterized by the 1517 chromosomal translocation, which forms the PML-RARA oncoprotein. This oncoprotein blocks terminal differentiation of the myeloid cells, causing leukemia. This is a unique disease in that it is very treatable and that it has a unique treatment, which is all-trans-retinoic acid, abbreviated ATRA, which is a vitamin A derivative. This vitamin A derivative, ATRA, it induces terminal differentiation in the cells and prevents malignant replication, thereby, in many cases, curing this disease. Historically, ATRA combined with some type of cytotoxic chemotherapy, usually an anthracycline, was the backbone of treatment. The new kid on the block is arsenic trioxide, abbreviated ATO, which came into first-line therapy for intermediate and low-risk disease in 2013, following Lococo et al.'s publication in the NEJM. Our center has substantial experience treating APL patients. We queried our EMR and pathology records from the time period 2005 to 2022 for any patients who had received treatment for APL at UMass, and extracted all demographic information, outcomes information, and adverse events information. When data was incomplete, we excluded that participant from our outcomes calculations. So to describe our case series of the demographics, the median age at time of diagnosis was 48 years, with a range between 18 years old to 82 years old. Just over 1/3 of patients were female. The majority were non-Hispanic white, 75%, self-identifying as such. In terms of disease risk at time of presentation, 25 patients had intermediate disease, 7 patients had high-risk disease, and 7 patients had low-risk disease. 29 patients received a treatment regimen that contained chemotherapy, whether that was in both induction and consolidation or induction alone, while 10 patients received an ATRA and ATO-based treatment without any type of chemotherapy. There was a 92% overall survival at median follow-up of 51 months, as well as a 92% 90-day survival, given that the only 3 deaths occurred within 1 week of acute initial presentation. These deaths are described on the timeline below, but occurred as consequences of severe disease, including DIC, pulmonary embolism, leukostasis, and severe sepsis, septic shock. Survival curves did not differ significantly by treatment group. You can see on this timeline down below that beginning around late 2013, 2014, treatment started to shift to ATRA-ATO only regimen. Outcome was focused on comparing tolerability between the 2 regimens. Did not turn up statistically significant, though the ATRA-ATO only groups had a lower transfusion requirement, had less ICU admissions, and did have a lower rates of DIC and ATRA syndrome. This group was significantly older than the chemo-receiving groups, which does suggest that it may have increased tolerability. It is likely that our low sample size for the ATRA and ATO only groups inhibited any of our outcomes from reaching statistical significance. Overall, the findings illustrate one-centered experience in the changing paradigm of treatment for this disease. My co-residents and I would like to thank our faculty advisor, Dr. Jan Cherney, as well as the rest of the hematology oncology faculty at UMass. Thank you very much.